Hello everyone, welcome back to my channel. I'm Dr. Durga Singh, and in the last video of emergency radiology, we learnt about cases related to the head, neck and few cases of chest. Let's proceed further in this series with new cases. So in this radiology and emergency part 2 video, we will continue discussing the remaining emergencies. They are pneumothorax, cardiac tamponade, blunt abdominal trauma, pneumo-peritoneum and intestinal obstruction. Moving towards our first case. A 35-year male met a road traffic accident, sustained a sucking wound in the chest wall and soon collapsed. Local people took him to the emergency department where the physician found the patient having tachypnea and tachycardia. His blood pressure was 80/50. On auscultation, there were no breath sounds audible. What next? Alright, first tell me the diagnosis. Yes, the history is suggestive of tension pneumothorax. Pneumothorax is a clinical diagnosis supported by hyperresonant note on percussion and decreased breath sounds on auscultation. If we investigate the patient, we get this film. See the given chest X-ray. Can you appreciate the hyperlucent right hemithorax with absent vascular markings? See the trachea, the mediastinum, they are pushed to the other side as there is compressive collapse of the right lung because of the presence of air in the right pleural cavity. See the collapsed lung is seen here. The outer border of the lung is smooth. It's the visceral pleura which is parallel to the parietal pleura or the chest wall. This is known as a visceral pleural line sign. Please remember, in case of pneumothorax, chest X-ray is taken during the phase of expiration. Also note there is role of E-fast in cases of suspected pneumothorax. Here we perform M-mode ultrasonography to look for the movement. Actually, USG chest is more sensitive than chest X-ray. See the USG films. See the normal lungs on ultrasonography. It's known as the seesaw appearance, where the waves are the normal chest wall with no motion and the beach depicts the lung-pleura interface movement. In case of pneumothorax, the sliding movement is absent, which tells that the parietal pleura and the visceral pleura are not together, demonstrating the barcode or the stratosphere sign. Remember, the investigation of choice in case of pneumothorax is CT scan. Now coming back to the question, what next? See, as pneumothorax is an emergency and diagnosis is clinical, we will proceed with urgent needle thoracocentesis in 5th intercostal space in the mid-axillary line, followed by the definitive management, that is tube thoracocentesis. Moving forward, our second case. A 30-year-old male met a road traffic accident, sustained few chest injuries. He became restless with respiratory distress and chest pain. Local people took him to the emergency department where the physician found respiratory rate of 30 per minute, pulse rate of 120 per minute and blood pressure of 80/60. On auscultation, heard sounds but not audible properly. What the physician suspected and what's the triad described here? Again, the diagnosis is clinical, which is supported by FAST or E-fast. Suspected here is cardiac tamponade, which is the rapid accumulation of blood in the pericardial space. And the triad is known as a Beck's triad, which includes hypertension, distended neck veins, that is raised JVP, and muffled heart sounds. On FAST or E-fast, the characteristic finding is diastolic collapse of the right ventricle with presence of intrapericardial fluid seen as the anechoic shadow between the pericardium and the heart. We manage the case by emergency needle pericardiocentesis, that is needle insertion in the subxiphoid space at 45-degree angle to the skin directed towards the left shoulder tip under guidance of ECG and echo. Alright, the third case. See the question. A 25-year-old male during a fight with few goons was hit by an iron rod on his abdomen. Soon he collapsed. He was taken to the emergency department where his pulse rate was found to be 120 per minute and blood pressure of 80 by 50 was recorded. What's the first investigation you will do? Okay, so this is a case of blunt abdominal trauma where the patient has become unstable. Initial investigation for this case is fast. Remember, in case of blunt abdominal trauma, if the patient is stable, the initial investigation is fast and the investigation of choice is CECT, while if the patient is unstable, the initial investigation as well as the investigation of choice both are fast. FAST refers to focused assessment sonogram in trauma, where ultrasonography is done by the emergency physician on an urgent basis. See the FAST film of this patient. Appreciate the black fluid in the Morrison's pouch between the liver and the right kidney. What can be this fluid? This is the blood collection due to trauma, that is Pneumo-peritoneum. So this case is fast positive where we have to perform emergency laparotomy through midline incision. Now few words about FAST. In FAST, the first site examined is the epigastrium where we look for cardiac tamponade, which is followed by the right flank to see the hepatorenal pouch of Morrison, then the left flank to look for any collection of blood around the spleen, and the last site is the pelvis as it is also one of the dependent area. In EFAST, that is extended fast, along with these 4 sites, we also look for the thoracic cavity, that is total 6 sites in case of extended fast. Alright, let's see the next case. Question says, a 25-year male is with history of long-standing peptic ulcer presented in the emergency department with pain abdomen since last night. Chest X-ray was done and we got this film. What's the diagnosis? See this chest X-ray film. Look for the air under the right dome of the diaphragm. This air has come from the viscous as it has perforated. This is a case of pneumo-peritoneum. The best X-ray to look for gas under the diaphragm is chest X-ray erect. But if the patient is unable to stand, then the preferred X-ray is left lateral decubitus. For this, the patient should be in that position for at least 10 minutes for the air to rise up. But the best investigation overall to look for pneumoperitoneum is CT scan. See the CT abdomen supine film of this patient. Appreciate the presence of air below the anterior abdominal wall. As we learn this, let's also learn few X-ray signs of pneumoperitoneum on supine abdomen films. Let's see. Falciform ligament sign means the peritoneal folds are lined by air. Football sign, abdominal cavity is outlined by gas from a perforated viscous. Most frequently seen in children with advanced necrotizing enterocolitis. Regular sign, visualization of both the serosal and the mucosal aspects of bowel wall as outlined by the air. Inverted V sign, that is air outlining the umbilical ligament. Cupola sign, air is present below the central tendon of diaphragm. And telltale triangle sign, that is air present between the bowel loops in triangular shape. Let's see the films. This is the falciform ligament sign. This is the football sign. This is the regular sign. And this is the cupola sign. So all these are the signs of pneumoperitoneum. Here I want you to learn about pseudo-pneumoperitoneum. For example, Chilaiditi sign. Here gas is seen under the right dome of diaphragm. This is actually due to the colon and a hepatic flexure that is interposed between the liver and the right dome of the diaphragm. Okay, and the last case for today. A middle-aged male patient presented with complaints of abdominal pain, vomiting, abdominal distension and obstipation. We did his abdominal X-ray and get this film. What's the diagnosis? See the X-ray film. Appreciate the centrally placed loops of small intestine with multiple short air fluids level. See the complete transverse mucosal folds, that is the valvulae conventus in jejunum. This is known as the step-ladder sign of small intestinal obstruction. Now see the second X-ray film. Appreciate the peripherally placed loops of dilated large intestine with long air fluid levels. See the hausturations that are characteristic of large intestine. This is X-ray film of large intestinal obstruction. The initial investigation for suspected intestinal obstruction is X-ray abdomen, erect one. That erect one is to diagnose the obstruction when more than 3 air fluid levels are seen. And the X-ray supine film abdomen is to know the site of obstruction. Feathery appearance says it's jejunum, featureless is the ileum, and colon shows the hausturations. With respect to size also, remember 3 is the size of small intestine, 6 for the large intestine, and 9 for the cecum. If these sizes are reached, it means obstruction is present and there is quite a high risk of perforation as well. Also note, if the patient deteriorates on conservative management, surgery is performed, where the first structure we'll look for is cecum. If the cecum is collapsed, means there is small intestinal obstruction. And if the cecum is distended, means there is large intestinal obstruction. Now it's time for the revision. Let's identify the films. This is the normal lungs on EFAST. These are the chest X-ray and the EFAST finding of pneumothorax. This is the fast positive case showing cardiac tamponade. This is the fast positive case showing the hemopperitoneum. They are showing the gas under the diaphragm due to the hollow viscous perforation, that is pneumo-peritoneum. This is the falciform ligament sign, football sign, wriggler sign, cupola sign. All these are signs of pneumo-peritoneum. This is small intestinal obstruction and this is large intestinal obstruction. With this, we are ending the discussion here. Hope you enjoyed the session. Thank you for watching and please ask your doubts in the comment section and let me know your valuable feedbacks. Thank you.